Hello and welcome. Oops, sorry. Hello and welcome to Audio Medical Basics. Now, as we said, we'll go back with the cycle and we'll go back to in case you didn't see it yet, the case files. The internal medicine book, we did 3 cases the last time, and now we'll do 3 more cases. And we'll go inshallah with this sequence. If you don't like it, let me know. Let's do other things. Today in the internal medicine case files, we'll start with the case of acute viral hepatitis, possible acetaminophen hepatotoxicity. So the summary of the case: a 20-year-old man complains of nausea, vomiting, diffuse abdominal pain, fever and myalgias. He has had 12 different lifetime sexual partners and currently is taking acetaminophen. He appears hysteric and has a low-grade fever and tender hepatomegaly. Results of his laboratory studies are consistent with severe hepatocellular injury and somewhat impaired hepatic function. So what is the most likely diagnosis? Acute hepatitis, either viral infection or toxic injury, possibly exacerbated by acetaminophen use. Most important immediate diagnostic test. The other question, the most important immediate diagnostic test is acetaminophen level, because acetaminophen toxicity may greatly exacerbate liver injury but is treatable. So, analysis, objectives of this case: understand the use of viral serologic studies for diagnosing hepatitis A, B, and C infections, know the prognosis for acute viral hepatitis, and recognize fulminant hepatic failure, and know the treatment for acetaminophen toxicity. Considerations: the patient has an acute onset of hepatic injury and systemic symptoms that predate his acetaminophen use. In this case, the patient used acetaminophen later after the symptoms appeared to treat his fever and body aches. The markedly elevated hepatic transaminase and bilirubin levels, the tests were done earlier, and they showed markedly elevated hepatic transaminase and bilirubin levels in this patient, and they are consistent with viral hepatitis or possibly toxic injury. This patient denied intravenous drug use, which would be a risk factor for hepatitis B and C infections. His sexual history is a possible clue. The degree and pattern of transaminase enzymes, ALT and AST, alanine aminotransferase and aspartate aminotransferase enzymes, the degree and pattern of their elevation can provide some clues to help differentiate possible etiologies. Transaminase levels more than 1,000 international units per liter are seen in conditions that produce extensive hepatic necrosis, such as toxic injury, viral hepatitis, and ischemia, shock liver. Patients with alcoholic hepatitis almost always has levels less than 500 international units per liter and often have an AST-ALT ratio of 2:1. In this case, it is important to consider the possibility of acetaminophen toxicity, both because the condition can produce fatal liver failure and because an effective antidote is available. By obtaining a serum acetaminophen level and knowing the time of his last ingestion, these data can be plotted on a nomogram. A nomogram is this thing. Can be plotted on a nomogram to help predict acetaminophen related liver damage and the possible need for N-acetylcysteine. Okay, so approach to suspected hepatitis. First, definitions. Hepatitis is an inflammation of the liver. At least 6 forms of hepatitis have been identified, referred to as hepatitis A, B, C, D, E, and G. Chronic hepatitis. Chronic hepatitis is a syndrome that is defined clinically by evidence of liver disease for at least 6 consecutive months. A syndrome that is defined clinically by evidence of liver disease for at least 6 consecutive months. Clinical approach. Viral hepatitis. Most common cases of acute hepatitis are caused by infection with one of 5 viruses, hepatitis A, B, C, D, or E. They can produce virtually indistinguishable clinical syndromes. Affected individuals often complain of a prodrome of non-specific constitutional symptoms, including fever, nausea, fatigue, arthralgia, myalgia, headache, and sometimes pharyngitis and coryza. This is followed by the onset of visible jaundice caused by hyperbilirubinemia, with tenderness and enlargement of the liver, and dark urine caused by bilirubinuria. The clinical course and prognosis then vary based on the type of virus causing the hepatitis. Hepatitis A and E both are very contagious and transmitted by fecal oral route, usually by contaminated food or water where sanitation is poor, and in daycare by children. Both hepatitis A and E infections usually lead to self-limited illness and generally resolve within weeks. Almost all patients with hepatitis A recover completely and have no long-term complications. A few may have fulminant disease resulting in liver failure. Most patients with hepatitis E also have uncomplicated courses, but some patients, particularly pregnant women, have been reported to develop severe hepatic necrosis and fatal liver failure. Hepatitis B. It is usually sexually transmitted. It also may be acquired parenterally, such as by intravenous drug use and during birth from chronically infected mothers. The outcome depends on the age at which the infection was acquired. Up to 90% of infected newborns develop chronic hepatitis B infection, which places the affected infant at significant risk of hepatocellular carcinoma later in adulthood. For individuals infected later in life, approximately 95% of patients will recover completely without sequelae. Between 5% and 10% of patients will develop chronic hepatitis, which may progress to cirrhosis. A chronic carrier state may be seen in which the virus continues to replicate, but it does not cause irreversible hepatic damage in the host. Hepatitis C is transmitted parenterally by blood transfusions or intravenous drug use, and rarely by sexual contact. The mode of transmission is unknown in approximately 40% of cases. It is uncommonly diagnosed as a cause of acute hepatitis, often producing subclinical infection, but is frequently diagnosed later as a cause of chronic hepatitis. Hepatitis D is a defective RNA virus that requires the presence of the hepatitis B virus to replicate. It can be acquired as a co-infection simultaneously with acute hepatitis B or as a later superinfection in a person with a chronic hepatitis B infection. Patients afflicted with chronic hepatitis B virus who then become infected with hepatitis D may suffer clinical deterioration. In 10% to 20% of these cases, individuals develop severe fatal hepatic failure. Fortunately, in most cases of acute viral hepatitis, patients recover completely, so the treatment is generally supportive. However, fulminant hepatic failure as a result of massive hepatic necrosis may progress over a period of weeks. This usually is caused by infection by the hepatitis B and D viruses or is drug induced. This syndrome is characterized by rapid progression of encephalopathy from confusion or somnolence to coma. So patients also have worsening coagulopathy as measured by increasing prothrombin time, rising. They also have rising bilirubin levels, ascites and peripheral edema, hypoglycemia, hyperammonemia, and lactic acidosis. Fulminant hepatitis carries a poor prognosis and often is fatal without an emergency liver transplant. So, fulminant hepatitis carries a poor prognosis. The mortality for comatose patients is 80%. Thank you for listening for part 1 of the acute viral hepatitis case from the Case Files Internal Medicine book. Please don't forget to like, subscribe, and comment, and come and see us in part 2. Thank you very much for listening.